Good morning. Welcome to our CU session on critical appraisals. So this week we'll have a session on Decide AI checklist. So we have been having a series of AI related checklists. Today it will be Decide AI on clinical decision support system, and Dr. Elbin has kindly agreed to take this session as well through as with our previous 2-3 AI sessions, and I'll hand over to Dr. Elbin for the same.
Thank you, sir. Good morning, everyone. Today, I'm going to talk about the Decide AI checklist, as sir had mentioned. I've been talking about various AI checklist guidelines over the past few weeks. But one thing which I did not mention was why should we actually critically appraise an AI-based studies? So AI-based studies are actually adds a lot of input to most of your studies recently, actually. But there are few things that we need to think of when we use an AI, when we use in studies as well as in day-to-day basis. The few things, problems that are, one is hallucination, that when we use AI multiple times, you get a lot of results which might not be from an actual guideline or an actual evidence. So it could be fake guidelines that we tend to overlook these things. Other thing is cognitive offloading, like using AI multiple times, mainly for students and all that who are doing studies and all. They might not actually have the actual reasoning for it, and they will completely depend on AI. So their ability to think and cognition is actually lost by using an AI multiple times. Then there's something called as racial and equity bias. So, for example, if you already have a specific guidelines or data which you already have, which already has an existing racial bias, and you fed it to an AI system, the results or the whatever the AI predicts as a model will also have that equity or that racial bias, which finally comes as an output. And there's also something called as de-skilling. This is something related to the cognitive offloading, that you use AI for generating multiple things, and finally you lose the skill of how to do things or procedures. And next is something called as an automation bias, where you're dependent on AI for a lot of things, and finally you don't know which one to take and which one not to take, and finally you take up everything. You don't know which one is right, which one is wrong. That is called as an automation bias. And there's also privacy risk when you feed data of patients into the AI system, that the things that are not to be publicly disclosed might go onto a public system that we don't know what, where else these information is being distributed to. So these are various harms of an AI system that we need to take into consideration while using. So because of all these problems, we need to always critically appraise any studies where AI has been used for forming a guideline or forming a prediction model or a randomized control trial where AIs have been used. So in the previous weeks, we have already covered Study AI, Tripod AI, Consort AI, and Cheers AI. So today I'll be talking about Decide AI checklist. So this is a checklist which is used for studies reporting an early stage clinical evaluation of an AI-based clinical decision support system. So I'll talk about what is a clinical decision support system. So it's something which we use day to day in our settings, actually, in our wards and all that. It's a computer-based tool that assists clinicians in decision making. So any computer-based tool that assists the clinicians can be a clinical decision support system. So it generally uses patient data or medical knowledge, or it can also use algorithms. And it is generally integrated with the electronic hospital records or computerized physician order entries or applications. So the various examples are even in our computer or software, we have a drug-to-drug interaction system, allergy alerts, which we have, sepsis early warning system, guideline-based treatment recommendations. We have vaccination reminders, risk prediction tools. All these are examples of a clinical decision support system. So generally, these are divided into two different types of clinical decision support system. One is a knowledge-based CDSS, which is you feed guidelines or whatever already pre-existing data, and then you give them you tell them to do, if these things are met, then you suggest this. Like that, you are actually feeding what to do to the system, and then it predicts what to be done. Other thing is an AI-based machine learning one where the multiple data has been given to the system and the AI incorporates all these data and finally arrives at a recommendation. Where the second one actually uses an AI or machine learning, and this is based on guidelines that we already set. So what are the benefits of the CDSS? It reduces medication errors, improves adherence to the guidelines because no one can actually memorize all the guidelines or whatever new things which are coming up every day. So it improves the adherence to the guidelines. It saves time and cost. It also supports the clinical judgment. But the challenges are alert fatigue. So if you have a notification system in your phone, you get multiple alerts. Finally, you disregard most of them and you don't know which one to take. And there's also data quality issues, like whatever data you're actually feeding into the system is finally being used to come out to a final analysis or recommendation. So depending on the data quality, the outcomes can also change. There's also something called as workflow disruption, that in your day-to-day works, you get a lot of alerts or whatever, and then it can actually disrupt your day-to-day work. And there's also a problem with trust and explainability also, like depending on what data has been used to finally arrive at a recommendation, whether you can completely trust that data also, which has been a problem with this. So where the Decide AI comes in is, so like I've already mentioned what is this tripod and study AI. So it is mainly for an AI-based test or a prediction model validation where the tripod AI comes in. So there's a preclinical development and then there is a offline validation. Then later on, where I had mentioned that we have a Spirit AI for RCT to see whether they have actually followed the guidelines. So this Decide AI comes in the early live clinical evaluation stage actually to look at the safety utility in small scale. This is where the Decide AI comes in. So the various items which are involved in the Decide AI is these, which are 17 items which they have described. So this also came out in 2024. So this is also a relatively new guideline or checklist which has come, and most of the studies which had been done before this, when AI has been used in all these clinical studies, they have not really followed it. So we will go on to see whether one of the studies which we are looking at is actually following these things. So I'll go on to a case scenario. So in the medical ICU of your hospital, most beds are occupied by patients on prolonged mechanical ventilation. And as an ICU physician, you find it difficulty convincing families about the limited benefit of this continuing aggressive care. And meanwhile, there are new patients with potentially reversible conditions which are waiting in the emergency department for ICU beds. And you have bed shortages because of this prolonged mechanical ventilation patient. And the MS asks whether you can use a web-based decision aid for families, which can be used to improve the understanding of the prognosis and support appropriate decisions about continuation or withdrawal of treatment. So to answer this question, I searched the literature and I got a study which deals with this. So this study actually uses an effect of a personalized web-based decision aid for surrogate decision makers of patients with prolonged mechanical ventilation. And it was an RCT which they have done. So it basically uses a decision aid, which is actually web-based. The surrogate decision makers are the people who actually decide for a ventilated patient as to what follow-up strategy should we follow for those patients. So this was done in those group of patients. So the first question in the Decide AI checklist is the title, whether the study identifies as an early stage clinical evaluation of a decision support system which uses an AI or machine learning. So this is a study title where they have mentioned that it is a web-based decision aid. And it is used for surrogate decision makers of patients actually. So in a way, it describes that this is a clinical decision support system. However, it does not clearly say that whether it's an early clinical evaluation or not. Because they have mentioned that they have done this as a randomized control trial here, but they did not specify whether it's an early clinical evaluation or not in the title. The second question is whether they had given a structured summary of the study. Using the intended use of the AI system, algorithm, study setting, patients, outcomes, all these things, whether they have discussed in the structured abstract. So the abstract is given in detail in the article, and it has the objective that they have actually looked at whether this decision aid would improve the prognostic concordance between the decision makers and clinicians compared to the usual control. And it was done as a multi-center study done in 13 medical and surgical ICUs. They've given the details of the participants, measurements, results, and conclusions. So they've given a structured, detailed summary of the abstract. Next question is the intended use. Describe the targeted medical condition, the problem, including the current standard of practice and intended patient population, as well as who are the intended users of this AI system in the study, and the study objective. So the targeted condition which they have looked at is patients who are on prolonged mechanical ventilation. And the targeted population was surrogate decision makers of patients on these ventilation and the clinicians and nurses who are actually taking care of these patients. And the use of the AI system was to decide about the goal of care choices for these patients. And the objective was to improve the prognostic concordance between the surrogate decision makers and clinicians. So the prognostic concordance would mean that, okay, if a clinician is telling the family that the person has got a chance of around 50% of living, then the surrogate or the decision maker will also have an estimate of maybe, I think my patient, my loved one would live 80%. So that is the, so there's a discordance of 30%. So that is what they intended to improve by using this web-based decision aid. So what they had mentioned, what are the current problems in the existing system is that most of the times the medical information is not shared completely. And what are the preferences of the surrogate decision makers? What are their actual roles in managing the patient? And because of all this, there is poor communication, comprehension with the decision makers. And because of this, finally, there is an inadequate shared decision making, which we actually want. And this would lead to decisional conflict among them. There is delayed decision making leading to prolonged ventilation in these patients. The expectations of the surrogate decision makers are most often not met. And finally, it leads to a psychological distress, increased resource utilization, and clinician surrogate discordance. So this is where a decision aid comes in, that they thought this would actually help in increasing this clinician surrogate discordance and decreasing all these conflicts and distress which they have. Now the next question is research governance. Did they give any reference to study protocol, registration number, and ethics approval? So they've given that it was already approved by the IRB board, and protocol is available in the supplement, and registration number is also being given. Participant describe how they recruited the patients, stating the inclusion and exclusion criteria, that is for the patients, as well as how they've recruited the users, which are clinicians and nurses. So their inclusion criteria was any patient who had been on mechanical ventilation for more than or equal to 10 days. And during the ventilation, whether any period of unassisted breathing was only for less than 96 hours. And anyone who is more than 18 years of age, and ICUMD expects that the patient will require ventilation for at least more than 24 hours. This is after completing 10 days of mechanical ventilation. So for the answer of any of these criteria is actually no, then they are not included in the study. And if all the answers are yes, then the patient is actually included in the study. And they had checked for eligible patients by screening of 13 medical, surgical, trauma, cardiac, and neurological ICUs in the US actually. Exclusion criteria is when they could not identify a surrogate decision maker for the patient, whether the patient is already waiting for an impending organ transplantation, presence of neuromuscular disease, whether they are admitted for severe burns, and legal guardians, which were the surrogate decision makers who did not actually personally know the patient, and surrogates requiring translation assistance, because they had actually, the web aid was only available in English, so it was not done in other languages. So people who required translation also was not included. And the ICU study investigator was also working in the same ICU. So during his study periods, they had actually not included patients to avoid bias, because he already knew how the intervention would work. So that was also not included. Now the recruitment of the users, which are the patient surrogates, clinicians, and nurses. So the primary surrogates were the adults who self-identified as the most involved participant in the decision making. And they had allowed unlimited number of additional surrogates also. In case there was a primary decision maker and even other relatives who were involved, they were also included. And each patient's ICU physician and the bedside ICU nurse was included as the clinicians or nurses. And regarding sample size calculation, they had estimated a sample size of 210. They assumed around 1.5 surrogates would be for each patient, with around 315 surrogates to have an 80% power. And they have actually detected this mean difference of 9%, which is actually that what is the initial concordance which they had, and then after they had conducted multiple interviews, and after the interview, how much percentage points would that concordance would change, and they have estimated that a mean difference of 9 percentage points should be there between an interview 1 and 2, and with an alpha error of 5%, dropout rate of 5% in the interview second. So finally they had come to an estimated sample size of 210 patients. So this was their how the study had actually went. So initially when the patients were selected after the first interview, so this interview had the surrogate decision makers as well as the clinicians and the nurses, and then they were randomized into a decision aid or a control arm. So the decision aid, the surrogate decision makers had viewed, and then after that the control did not have the decision aid. So this was done on the first day or between first or third day. And then finally the decision aid viewing was also done within that day, and then they had a family meeting, which whatever usual family meeting which happened for all the ICU patients they had for both the groups. And then they had another interview, second interview. So what they had mainly looked at, the primary outcome is the difference between this concordance from the first interview and the second interview. And then this should have been completed by the 9th day, actually, the second interview. And then they had again followed up these surrogates and the clinicians and nurses and done interviews in 90 days and 180 days. So these interviews of the patients have already been discharged, they have done through telephone interviews. They have done. So next is briefly describe the AI system, specifying its version and the type of algorithm used, and describe or provide any direct reference to any study population on which the algorithm was trained. So they have used a Provent prediction model for 1 year survival. So they had a 10-day version of the model as well as a 14-day version of the model. For example, if the patient has already completed 11 days of ICU stay or ventilation, they had used a 10-day model. And if they've already completed more than 14 days, they used a 14-day model. So what this model would do is they would predict a 1 year mortality for these patients, and then they would say this much is a mortality for that patient. And then there was an interface to the surrogates also, who can go through the details of these patients and then decide what to expect for them. And then they have done the development and validation of this model in a previous study, and the reference for the study is given in the article. Identify the data which was used as inputs and how the data was acquired and any pre-processing which is applied, and how they had handled the missing data. So the predominant data, which was mainly the 5 variables which had look at the main mortality, which was age, platelet count, whether there was any presence of renal failure, use of vasopressors, and admission for trauma. These are the 5 predominant variables they have used, but they have used other variables as patient characteristics of whether they have comorbidities, illness severity, functional status, ventilation duration, invasive treatments, and even surrogate decision maker characteristics also was fed into the system, and even the clinical characteristics have also been fed into the system. And describe how missing and low quality data was handled. So they have mentioned that they use something called as a pattern mixture model for missing data. So what I understood from this is basically what is a pattern mixture model is. For example, you have a missing data. For example, they are assessing the variables at different points in time. So so some data could be missing at the first interview, some could be missing at the second interview, and some could be missing at the third interview. So there could be a pattern for these data as well. So they group it into different groups based on these pattern, and they do some sensitivity analysis at the end of it so that they account for whatever missing data was already there. So this is how the output was actually given by the AI system. So they initially had a welcome page where they'd actually defined what is a decision maker and how should you decide on what to be done for the loved one. And then this is the first page where they describe to them what is the medical problem, what are the treatment choices available, what are the goals of treatment that you would actually expect, and what is important, what does that particular patient would want, and how should you make decisions. This is the first page that they have, and then they go on to how they had actually given the prognosis for these patients. So they had said that for everyone, like we generally describe, imagining 100 patients with the same medical conditions as their loved one, And then they say that each circle represents, so they had actually clearly described so that anyone could actually understand what they were actually describing. So they had said that each circle represents a patient. And then finally, what would happen to these 100 patients with the same medical conditions from 1 year from now? That means what would be their survival? So after 1 year, 31 are at home, 13 are in a nursing home, and 56 have died. So the surrogate decision maker goes through all of these slides by themselves, and finally they come to this slide where what do you want based on this prognosis for your patient. So whether you want to maximize the comfort, or whether you want to maximize survival, or you want to aim for survival but avoid prolonged treatment. So they've also said what it would mean by maximizing comfort. So whether loved one may be comfortable, or they would do invasive procedures, or they might lengthen the life for some time, or ensuring comfort is a main priority, or loved one may be still die or disabled. So depending on various strategies, what they should expect when they choose each of these strategies also was given, and they had also clearly described what was each of these strategies actually. And then they go on to this slide where they ask what would your patient would want, whether they would want trouble doing everyday activities, whether they would want to do, they will be willing to be unable to do any activities, or they want to do all daily activities if they are actually alive. And then do you want your patient or relative to have some serious trouble with thinking, or completely normal thinking at the end of it? And then what is the percentage of survival that you would expect for your patient? And then finally, is length or quality of life important for the patient? And what goal of treatment do you feel is best for the patient? So this involves maximizing comfort, aiming for survival but avoiding prolonged life support, maximize survival, or they are unsure finally. And then this gray rectangle is basically what finally they've arrived at based on their previous decisions. And this is the red rectangle which they had actually given if they are actually agreeing with their final decision, or do they want to change to a separate decision or not. So this is what the web base would have suggested based on their previous preferences, and this is that if they want to change that, they can actually change it. And finally, is there any conflict related to the decision, or they can finally go with this decision? And finally, what else would be helpful in making the decision? So do they want to know what the medical team recommends? Do they want to talk with family and their friends? Do they want more time to think? Do they want to talk to a chaplain? Do they want to know more about prognosis or treatment or whatever? And then finally, they decide whether they want to take the decision by themselves, or whether medical team should make the decision, or they want to discuss with family and friends. So finally, this is the final page they arrive at. And then after going through this process, they get a structured summary of whatever they had actually opted for. And these copies are actually given to the surrogate decision makers, and also to the clinicians, and also to the nurses who are actually involved in the patient care. And next is implementation. Describe the setting in which the AI system was evaluated. So here the setting was 13 medical and surgical ICUs and 5 hospitals, and all hospitals were actually in the US. And this was the clinical workflow pathway which I had previously mentioned. So after this decision aid viewing, there is a family meeting which is conducted, and then there is the second interview in person with surrogates, physicians, and nurses. Then at day 7 also there is an interview with surrogates, physicians, and nurses. Then there is a 4th interview and 5th interview, which is probably after discharge from the hospital, which is done through a telephone conversation. Now regarding the outcome, what is the outcome they have looked at, and whether they have specified that? So the primary outcome they have looked at is the clinician surrogate concordance scale, which is actually the difference between the ICU physician and surrogate regarding the prognosis. So they ask them a question of what % chance do you think the patient or your loved one has of being alive 1 year from now if the current treatment plan is continued. So maybe if the physician says 40% and the decision maker says 70%, discordance is actually 30%. So that is this clinician surrogate discordance. So they have actually did something. So they've done interview for the intervention group at day 1 and the date 3, like they initially mentioned. And then they found out, okay, in the first interview, if the discordance is actually 30%, they found out after the decision aid viewing in the second interview, what is the discordance. If it is 25%, then the decrease in discordance or the difference is actually 5%. The same thing they have done for the control as well. They had the initial interview and then the second interview without the decision aid viewing. So in case theirs was 35 and then 30, I mean 35 and maybe 29, theirs is actually 6% difference. So then they actually found out the difference between these two, which is 6 minus 5, which is 1% difference which is there. So that is the discordance, clinician surrogate concordance scale they have actually looked at. And they've also looked at multiple secondary outcomes, which is different scales they've looked at mainly for how much they had actually comprehended or understood when these things were being explained to them, how much was the satisfaction with the clinician communication, how much psychological distress they were in, whether they had in post-traumatic stress symptoms, how much decisional conflict they were in, and something called as patient-centeredness of care scale. So this is one scale which they use, which they have used to assess the safety of this, intervention actually, because in this what they have looked at is at 6 months or 9 months, whether the patient-centeredness of care scale would mean whether the surrogate decision makers felt that finally whatever choice they had made is actually a patient-centered decision. And the value is actually from 0 to 48. So if 48 is the highest value, so 48 would mean that the surrogate decision makers felt that whatever decision made was actually a patient-centered one, and they were satisfied with the decision which they had taken. Next question is whether they had given a description of how significant errors or malfunctions were identified and defined. So they had not given any description of how errors or malfunction could be identified or defined, and describe how any risk to patient safety or instance of harm were identified or analyzed. So as this is a web-based decision aid, which they just have to view and decide what to do for the patient, there is no direct safety to the patient or any harm which is actually involved. And then this is the only thing which they have, like I previously mentioned, patient-centeredness of care scale, which they have actually done to see whether, for example, one harm would have been because whether a decision aid would have most of them deciding a comfort care, and finally a lot of patients would finally die in the intervention arm, and whether they had a good prognosis at the end of it. That is one thing which could have been a harm which could have come. That's why they had indirectly used this patient-centeredness of care scale, where they have said that if the relatives are actually confident at 6 months or 9 months that, okay, whatever we have chose for the patient was actually the right decision, then even if the mortality was slightly increased in the intervention group, this is an indirect way of saying that, okay, but that was not probably a harm. That is what the patient-centeredness of care scale would mean. So that is what they had used here as a safety outcome here. And human factors, describe the human factors, methods or frameworks used, the use cases considered, and the users involved. So they have conceptually grounded this web-based decision aid based on an existing framework, which is an Ottawa decision support framework. So this is a framework which actually support individuals' decisional needs. So this is one framework which is originally developed by Dr. Annette M. O'Connor, which is a nursing scientist who developed it in 1990s. So this actually deals with decisional needs for different group of people, and then they give decisional support by clinical counseling, multiple decisional tools or decisional coaching. And finally, they help them in arriving at a final decisional outcome. So it's currently developed and run by Ottawa Hospital Research Institute in Canada actually. So this personalized web-based decision was also based on this decision support framework which had actually put forward. And the users were, like I mentioned, it was to the clinicians, surrogate decision makers, and staff nurses. Now, regarding the analysis, describe the statistical methods by which primary and secondary outcomes were analyzed. So they have used something called as a generalized general linear model fitted with a generalized estimating equation. So this is something similar to a linear regression that you do, that you have an outcome which is a continuous variable. You use a linear sort of regression to find out what is it. But here, like I mentioned, they have looked at the difference between the concordance between both groups, which is intervention and control. So it's not really a continuous outcome there. So, and it's also not normally distributed. So this is a type of an analysis which they use to incorporate that part of, if it's not normally distributed, to incorporate this generalized linear model that they've used. And they've used the same model for the secondary outcomes as well. Now describe whether specific methodologies were used to fulfill an ethics related goal. So they have not used any specific methodologies, or they have not specified it in the articles for an ethics related goal, or to have a fair algorithm for all the patients. But they have said that the protocol was already approved by the IRB board, and there was also an independent data safety monitoring board which was there. And regarding the design of the study or development of research question or conduct of the study, no patient involvement was there. Now regarding the baseline characteristics of the patient included in the study and whether they have actually reported that. So these were the baseline characteristics of the patients which are involved. So it is a busy slide. So finally what they had looked at is most of the patients were Caucasians who were more than 50 years of age, and most of them were admitted for ventilation because of a pulmonary, neurological or a surgical cause, and most of them were admitted in a medical ICU, and their predicted mortality was actually 40%, most of their predicted mortality at 1 year. Now these are the surrogate decision makers characteristics that they've looked at. So most of them were 40 years of age, most of them were female, mostly spouse of the patient, with at least a high school education and employed currently, and most of them were Christians who were the surrogate decision makers of the patients. Now regarding the ICU physicians and nurses, what were their characteristics? So they were also Caucasians male, and most of them were attending critical care physicians, and nurses were also similar. So this is their final diagram which they've given, where they've actually assessed 2,455 patients for eligibility. Finally, in the intervention, they had 138 patients, and in the control, they had 139 patients. And finally, at interview 4, they had around 74% primary surrogate decision makers, which is almost 26% lost to follow up here, and around 14% lost to follow up in the control arm there. So this is the final diagram which they had given. And regarding the implementation report on the user exposure to the AI system and the number of instances the AI system was used and the user adherence. So mainly when we use an AI in a system, we also need to know how much the people actually adhered to the AI system, how many people actually used it. So they have found that almost 92% of surrogate decision makers completed the decision aid during their intervention actually. And they did not have any significant changes to the clinical workflow or pathway caused by the AI system. They have not mentioned anything explicitly in the article regarding any change in the workflow. Now going on to the main results, whether they've reported the specified outcomes for or outcomes for any comparison group. So they've looked at this thing, which is the clinician surrogate concordance scale. So this is the intervention time. What is the estimated score? So this is during the first interview in the intervention arm. The concordance was 33, which is 33%, and then at interview 2 it was 27. That means after the decision aid viewing, it was decreased to around 6% here. Now same in the control, initially it was 34, it is decreased to 29. So there is a 5%, around 5% difference. So they finally looked at this difference, which is around 6 here, and then they have also looked at this difference, which is 4.8, and then what is the difference between these two differences, which is minus 1.7, with the confidence interval of minus 8.3 to 4.8, which actually crosses 1. So they did not have any significant difference between the intervention and control group in the concordance scale, even though they've used actually a decision aid here. And they've also looked at some secondary outcomes, which is how was their anxiety scale and how was their comprehension scale and all that. So regarding the anxiety scale that they've looked at, so in the anxiety scale also the score ranges from 0 to 21 actually in the anxiety subscale, with the higher scores indicating greater distress. So their initial anxiety scale was 9.2, which reduced to 8.4 in the intervention, and their initial anxiety in the control was 9.4, which reduced to 8.9. Even there is no significant difference actually. It is almost similar actually. And then going through that decision aid, we might feel that this is explaining very clearly that maybe they would have understood it more. They would have comprehended or understood it finally more. So they've also looked at this median comprehension scale also. So in the comprehension scale also, it was 4.6 in the beginning, which increased to 5.4. Even in the control group, it was 4.8, which increased to 5.3. Even there also, there was no significant difference actually they had observed between the intervention and control group. So this is the other score which I had mentioned, which they've indirectly looked at a safety outcome where the patient-centered care scale which they've looked at. So as I said, 48 is the maximum score, which means the treatment was highly patient-centered. So in the intervention group, it was actually 42.7. And in the control group, which was around 41.3. So there was no significant difference. This is at 3 months when they've looked at. Even at 6 months also, it was 42.7 and 41.8. There was no significant differences in that as well. So finally, most of their primary and secondary outcomes that they were actually described in the beginning, they did not find any significant difference, even though they had expected they would have found a difference. They expected 9% of difference between the concordance between the intervention and the control group, which they did not get. Now, few clinical outcomes which they have looked at is what is the mechanical ventilation days. So they had assumed whether they've used the intervention, maybe the mechanical ventilation days would have come down in the intervention group. But after randomization, mechanical ventilation mean days were 15.3 in the intervention group and control was 13.7. So it was actually increased in the intervention group. And hospital stay also was 42.8 in the intervention group versus 39.5 in the control group. So intervention group had an increased hospital stay. And mortality, so they had expected that their mortality is around 40%, which is at 1 year. So patients who died in the hospital were 34.1, this is before discharge, and 28.1 in the control group. And at 6 months, the mortality was 40.6 and 38.1, which is also almost similar in both the groups. Maybe slightly increased in the intervention group here. So there also, they did not find any significant difference, even in the clinical outcomes also. Now, finally, after hospital discharge, even the patients who are home independent and patients who are in a rehabilitation facility, skilled nursing facility, everything was almost similar in both the groups actually. There was no significant differences which they could arrive at. So next is report on differences in the main outcomes according to the pre-specified subgroups. So they did not do any subgroup analysis here. So there was no subgroup analysis done. And any changes or modifications which was done to the AI system during the study process. So they have not reported any modifications which they have done in the article to the algorithm or the AI system. Now next is whether the user agreement with the AI system. Describe any instances or reasons that user variation from AI system's recommendations. That means the AI system recommends that the patient needs to go on to a comfort care versus the surrogate decision makers decides, no, I want a all-out care for the patient. What is that disagreement? So they have given a diagram like this where this is what I had already mentioned, that this is what the decision aid would suggest, saying this would be best for the patient based on their previous decision. But this is what finally they can change their decision based on that. So finally, based on the web-based decision aid, you can see that they've divided into different domains, which is one is comfort focused care, second is comfort focused but hoping for survival, next is aim for survival but avoid prolonged care, and then avoid prolonged care but leaning towards aggressive care, and aggressive care, which is the all-out care. So you can see the numbers here that in the comfort focused care, it was 6, 46, 97, 34 and 9. So the number of percentage of people were more in these two groups actually, 50% and 24%. So you can see that finally what surrogate decision makers decided after viewing this thing was in the comfort side. This is mainly the maximizing the comfort area. There the numbers are actually lesser compared to what the decision aid had suggested. So you can see that even though the decision aid suggested 6 people should go for a comfort care, the surrogate decision makers, 4 of them agreed, but 2 of them felt that no, my patient should have a little more aggressive care. The same way as each of the goals they've looked at. So when they looked at finally in the aggressive care, these decision aid suggested only 9 patients should go for an aggressive care. However, the surrogate decision makers decided that 39 patients should go for an aggressive care. So you can see that they have more of a right shift here from the comfort care. The orange diagrams actually represent how many people actually shifted from the comfort side towards an aggressive level of care, and very less number of people actually shifted from right side to left side, which is from an aggressive care to a comfort based care. So even though the decision aid was actually intended to make them lean towards a more comfort based care, they had kind of shifted to an aggressive based care after viewing the decision aid here. So regarding the safety errors, list any significant errors or malfunction related to the AI system. So they have not reported any malfunctions or errors in the article, and they also does not report anything related to the patient safety or indirect harm, except that whatever that patient-centered care scale which they have mentioned. And also here, one indirect harm here is like, okay, most of them, even though we had intended to make them lean towards a comfort-based care, most of them went for an aggressive level of care. So it could be an indirect harm when we look at from the patients or the surrogates perspective. And finally, the mortality which was equal in both the groups, even in the intervention and control. Now, report on the usability evaluation according to the recognized standards frameworks, or report on the user learning curves evaluations. So, so they have actually asked in the Decide AI checklist whether they have given a learning curve. So what a learning curve would mean, this is a learning curve for the user actually. So surrogate decision makers, clinicians and nurses are actually using this AI system. So whether continued use over time would improve the performance of the already existing model. So the ideal learning curve would look like this. The performance actually increases as the time goes by. But they have not given this learning curve or usability evaluation, but it could have been because it is not the same people who are actually using it again and again. So every time it's a different surrogate decision maker and a different clinician or nurse who is actually coming. And they have also mentioned there was not much same group of clinicians who had repeated, but around 12% of the clinicians who had already done the intervention had actually done a control for a different group of patients actually. So they could have actually provided a learning curve for the clinicians and nurses, maybe not for the surrogate decision makers, but they had not given that in the article. Now, next 15th question is whether they have discussed whether the results obtained support the intended use of the AI system in the clinical settings. So what they had intended to achieve by this AI system was to improve the prognostic concordance, but they could not achieve that, and they have actually given in their discussion also that personalized web-based decision aid did not improve the prognostic concordance between the clinician and surrogates. And they have also given that they also expected that it would improve the comprehension, decrease the depression, but none of that outcomes they had actually achieved after the study. Next is the safety and errors. Discuss what results indicate about the safety profile of the AI system. So safety profile, they did not report any specific. So this is what I would have wanted as a safety profile, that if the decision aid had suggested a comfort care and the surrogate decision maker had gone for an aggressive care, finally whether that patient actually lived at the end of 90 days or 1 year. If that is there, this would have been a harm. But they have not reported anything like that in the article. And however, whatever the patient-centered care scale they have reported is actually high, which would mean most of the surrogates are happy with whatever decision they have finally made. Discuss the strengths and the limitations of the study. So this is what the strength and limitation they have described in their article. So the strength was, they've said that it is the first multi-center randomized trial to test a decision aid in the acute care setting. And their development of the decision aid was rigorous, and whatever protocol they have actually formed in the beginning, they had actually adhered to it, and then their 6-month follow-up rate was also higher. Around 24% loss to follow-up was there in intervention, and around 14% in the control. And the limitations they mentioned is the possible unmeasured physician level effects, which would mean that, for example, a physician who, if they know if they're in the intervention arm, they can actually decide on how much they should actually invest by talking to the patient relatives in the intervention arm. So those could have been the unmeasured physician level effects. Other thing is potential contamination among the clinicians. So like I mentioned In their study, the clinicians who were in the ICUs actually. So the clinicians who had attended one of the patients initially in the intervention arm, later on could have gone in the control arm for another patient. So they would have already known what the intervention would have suggested, and they will know, and the way they describe also would be different. So maybe there could have been some contamination. This could have been the reasons why they have explained that they did not get the intended results after the use of this system. Now, regarding the data availability, if the data and relevant code are available, so they have indicated in their data sharing that they will not be sharing the data. And the reason also they mentioned that it is an active use by the junior faculty at the institution. So they have mentioned that in their article, and the study protocol is available in the supplement they've mentioned. And any conflicts of interest they have disclosed, there are no conflicts of interest in any of the others. Now going on to my case scenario, so here the personalized web-based decision system is actually well done, and the way they have described it is actually good, but finally they did not intend to achieve what they had actually expected that the decision aid would achieve. So I would not suggest using this personalized decision for support for any additional benefit, because it is not, the current study does not show any additional benefit. So regarding the Decide AI checklist, they had mostly followed whatever is the initial part of it, but maybe towards the end regarding some safety and those things they did not follow actually. Thank you. I would like to thank Dr. Tambu sir and Vignesh sir for helping me doing this presentation.